Good morning. Today is January 21st, and we are so happy to welcome, we have some guest speaker, but the person who knows him the best, and knows this Jewish genetics, this topic the best, is our own Dennis Kessler. And when you say own, that means they belong to Macomb Solel Lakeside. So without any further ado, Denny, if you could introduce our speaker. I'm not going to take I don't want to take any of the words out of your mouth.
I'm happy to. Good morning, everyone, and thank you, Vanessa, for arranging this program about Jewish genetics, and thank you for all the wonderful work you do all year long in bringing adult education to Macomb. It's my privilege this morning to introduce Scott Weissman, representing the Sarnoff Center for Jewish Genetics. The center operates as a division of the Jewish Federation of Chicago. I serve on the board of the center and was one of the founders in 1997. Scott graduated from the University of Illinois at Urbana-Champaign in 1998 with a BS in biology, and he completed the graduate program in genetic counseling at Northwestern University in 2002, earning his master's degree in genetic counseling. Scott has been practicing in the field of adult genetics for over 20 years, with a focus on hereditary cancer syndromes. In 2016, Scott opened his own private practice providing genetic counseling services. The firm is called Chicago Genetic Consultants, LLC, and he joined the Sarnoff Center for Jewish Genetics in 2023. Scott helps educate the Jewish community about relevant genetic conditions that impact our community, as well as run the center's carrier screening program. Scott, welcome to Macomb Solel Lakeside. We're anxious to hear your talk.
Well, thank you for inviting me to come and speak to you all today. It's a pleasure to be here with you on this, looks like sunny, but still cold Sunday morning. Let me share my screen and then we can go ahead and get started. All right, so can you all see the slides?
We can see them.
Perfect. All right. So what I will be speaking to you this morning about is what we generally call Jewish Genetics 101, what you need to know. And the talk is really going to focus on Jewish genetics, specifically related more towards adulthood. So we're going to be talking about hereditary cancer syndromes. We're going to spend some time talking about something called dystonia that some of you may be familiar with. And then we're going to talk about recessive disorders that really are involved with family planning. And not just so much kind of sharing this information, but also what you can do with this information, how it can potentially impact you or your family. And so one of the things I just want to go back to for a moment that Dennis talked about is I am here today representing the Norton and Elaine Sarnoff Center for Jewish Genetics. So it is a division of JUF, and what we do is provide education on the recessive Jewish genetic disorders for individuals who are starting their families. We talk a lot about hereditary cancers as well, because as we'll learn today, there are several genes that are more commonly seen in the Ashkenazi Jewish population that can increase the risk of cancer. And we provide genetic counseling and testing for these different conditions. What's great is that people can have access to a genetic counselor like myself that can help identify resources. And really one of the most valuable things I think that the center does is they provide a subsidized carrier screening program for people that live in Illinois who are getting ready to start their family. So I just wanted to give a little bit about that background about the Sarnoff Center. Okay, so what is Jewish genetics and how does it affect you? And we're just going to level set with this slide. For those of you that haven't taken a biology course in several years, just to recall that essentially your genes, which are those packets of DNA, they are responsible for producing proteins that your body needs. So genes determine your eye color, your hair color, to tell you how tall you're going to be. We have other genes that serve important functions where if the genes don't work correctly, or if somebody has a mutation in a gene that causes it not to work correctly, then the body potentially can't function exactly as it should, and this in some situations can lead to disease predisposition. And there's lots of different ways that genetic disorders can be passed from generation to generation. During the talk today, we're really going to focus on two kinds. So on the left, you have what are known as recessive disorders. So with a recessive condition, an individual needs to be born with both copies of the gene, one that they get from mom and one that they get from dad, that are not working correctly. So in this image, the non-working gene is the kind of pink bar here. And so typically when individuals are said to be carriers, where they have only one non-working gene, that really isn't enough to impact somebody's health. But if, again, two people come together that are carriers for the same condition, when they have children, there's basically a 1 in 4 or a 25% chance that they both can pass along the gene that isn't working to their child, where their child would then be affected with that particular genetic disorder. There are also dominant conditions. So for dominant disorders, again, if we're looking at one gene, so the pink bar here that isn't working correctly, for dominant disorders, you only need one copy of the gene that isn't working or mutated to be at risk of the genetic condition. So if somebody has a dominant disorder, every time that individual has children, they're going to have a 50-50 chance of passing it on to the next generation. So where some people think that genetic disorders can skip generations, that skipping, if you will, is more linked to the recessive disorders. But dominant disorders, it's passed along or it's not, and it stops and it won't skip generations. So recessive disorders can skip generations, dominant disorders cannot. And so what makes a genetic disorder Jewish? Well, people of Jewish descent, both Ashkenazi and Sephardic, we just know through studies that we are more likely to carry variants that can predispose to disease. We're actually, depending upon this order, sometimes 20 to 100 times more likely to be carriers of conditions. And these are conditions of variable severity. They can onset in childhood, they can onset in adulthood. Some have treatment options, some don't. And really, the reason why there are so many conditions that are more common in the Jewish population is something that's referred to as the founder effect, where you may have an original population of people where maybe one person is the carrier for the genetic disorder. And then you have an event where there's a sudden and marked decrease in the population of that particular group. You have events like the diaspora or the Holocaust, where you had large swaths of people of Jewish descent that were essentially killed, where you maybe are left with a small group of people that are left to kind of create the population moving forward. And if one person in that kind of founder population has that genetic disorder or is a carrier, as they repopulate, it can then become more common because it started with an initial founder. And so that's why there's these conditions that are more commonly seen in the Jewish population. You can have a population like the people of Iceland who are really geographically isolated, where they can have the same issue where, because people aren't necessarily coming and going frequently from Iceland, there's more conditions that are common in that population. So there are a lot of different effects that can happen that can lead to this founder effect. So I like to do a little myth busting here, a little true or false, because we hear lots of different things, I think, in the Jewish community where, some people think, all groups of people face genetic health concerns, not just people of Jewish ancestry. And that's absolutely correct. Every ethnic population has some specific condition that is more common in that population. People from the Mediterranean, African Americans, French Canadians, Asians. I mean, really every ethnic population has something that they're a little bit more likely to be carriers for based on their ethnicity. And again, understanding that being Jewish isn't an ethnicity it's really kind of speaking to people that are of Eastern European descent who identify as Jewish. Jewish genetic disorders don't affect only people who have Jewish ancestry. And that is also true. All the conditions that we're going to be talking about today can be found in anybody of any particular ethnic background. It's just some conditions are seen more commonly in people of Jewish descent. And people who are of Jewish descent can also develop conditions that are not common in people of Jewish ancestry. And the last one is even people who have a little bit of Jewish ancestry have an elevated risk for Jewish genetic disorders. And that too also is true. You know, essentially, all you really need is one grandparent or one great-grandparent where, you know, maybe you have 10, 12, 15% of Eastern European Jewish genetics that have been passed to you, then you would potentially have a chance of having something that is more common in the Jewish population. So let's switch gears and let's talk about our first set of conditions, which are really hereditary cancers. So I think it's important to know that all cancer, no matter where it starts in the body, is genetic. For a normal cell in the body to become a cancer cell, it has to go through a series of genetic changes that are harmful to the cell that basically transform it from a normal cell to a cancer cell. So all cancer is genetic, but only a small proportion of cancers are hereditary, where there is one single gene that's being passed from generation to generation that's causing a much higher chance of getting very specific cancers. And so, as I just mentioned, you know, hereditary cancer occurs when somebody is born with a genetic mutation that can increase their risk for developing certain cancers. These gene mutations can be passed down through families. The vast majority of genes that we know about that can predispose to hereditary cancers are passed along in a dominant fashion, so that 50-50 chance. There are a small handful of hereditary cancer conditions that can be recessive, though. So predominantly dominant, but a few recessive conditions. And as I mentioned, only a small proportion of cancers are hereditary, and that percentage is about 10%. So the vast majority of people who develop cancer, it really occurs by chance, or what we would say is sporadic in nature. Nothing somebody did or did not do, it just happens completely by chance. There is this kind of middle piece of the pie here that is, let's go back one second, that is called familial cancer. So familial cancer is a little bit more of a stronger genetic relationship where several individuals in the family may share several different genes that just maybe slightly increase the risk of getting cancer. And then because it's family, they may live in the same area, have some of the same environmental exposures, have some of the same lifestyle choices, that when you combine the genetics plus the environment plus lifestyle, you can maybe see 2, sometimes 3 people getting the same cancer in a family, but it's not due to a single gene that would classify it as hereditary. As I mentioned a few moments ago, the development of cancer is really a multi-step process where you have a normal cell, and just due to normal living, getting different types of exposures, a cell can spontaneously mutate in a gene. It can just develop a genetic mutation. And usually it's not one gene mutation that's enough to really cause cancer, but if the cell keeps mutating and you get lots of them, which are identified by these different red and pink bars, then that normal cell can turn into a cancer cell. So with sporadic cancers, there's really no mutations that are inherited. These mutations tend to develop and people acquire them over life. And over the course of time, it can turn into a cancer cell. That's why most people who develop cancer, it tends to be later in life because it can take a lifetime to develop these different types of cancers. However, for people that have a hereditary cancer risk and they are born with one mutated gene, they still need to go through that same process of developing other mutations before they'll turn into a cancer cell, but it's just usually over a shortened period of time because they start off kind of one down. And so for people that have a hereditary cancer risk, you may often see cancer at earlier ages, which is under the age of 50 is considered early. There are certain characteristics that you can see in families that may give you a clue that there could be something hereditary responsible for the cancer. And these are kind of the different red flags where you see young age of diagnosis. Again, that is under the age of 50. You're seeing multiple generations with cancer. You may see multiple individuals with the same type of cancer. So multiple people with colon in the family, multiple people with breast cancer in the family. Rare types of cancer. So men with breast cancer is a less commonly seen cancer. An individual who has had multiple cancers. So not so much cancer that spreads to different parts of the body, but they get cancer, it's treated, it doesn't come back. Then they go on to develop a second, completely unrelated cancer. Sometimes people can develop third cancers. That can be a red flag. And then the final one there are some high risk ethnic groups where that would make you think about, if you see a couple cases of cancer in the family, that there could be something hereditary going on. So the biggest genes that are responsible for hereditary cancer in the Jewish population are the BRCA1 and BRCA2 genes. So I'm guessing that probably most of you have heard about these genes at some point. These genes get a lot of exposure in the media, and mutations in the BRCA1 and 2 are very common. So if you were just to go on the street and start randomly genetically testing people for the BRCA1 and 2 genes to look for mutations, you would need to test about 300 people before you would find one person that has a mutation in either of these genes. However, if you were going to do the same thing and just test people of Ashkenazi Jewish ancestry, you'd only need to test 40 people before you find one person that has a mutation. So mutations in BRCA1 and 2 are about 10 times more common amongst the Ashkenazim than in the general population. And if you actually start looking at people that have had cancer, so you take any Jewish woman who's had breast cancer, there's about a 10% chance that her breast cancer is due to a BRCA1 or 2 mutation. If you take any Jewish woman with ovarian cancer, there's about a 40% chance that it's due to a BRCA1 or 2 mutation. Not on this slide, but if you take any man with prostate cancer, there's about a 7 to 10% chance it's due to a BRCA1 or 2 mutation. And if you take any Jewish individual with pancreatic cancer, there's about a 10% chance it's due to these genes. And it's important to know this because, first of all, for women, having a BRCA1 or 2 mutation can significantly increase the chance of developing breast and ovarian cancer. So for most women, the chance of getting ovarian cancer at some point in the life is about 1.5%. But with mutations in the BRCA1 and 2 genes, that risk goes up from on the low end to about 10%, but on the high end, about 54%. The chance of getting breast cancer goes from about 12% to anywhere from 40 to 80%. So again, much higher chances of these cancers developing. I mentioned prostate cancer in men. Men that have mutations in BRCA1 or 2 can have upwards of a 60% chance of developing prostate cancer. Men and women have about a 7% chance of developing pancreatic cancer. Breast cancer in men, it's about a 7% chance, and then melanoma is about 3 to 5%. So these are other cancers that you can see with BRCA1 and 2. These by far are the most common cancers, but sometimes you can see other cancers related to BRCA1 and 2 as well. Now, what's important is, BRCA1 and 2 have been around for a long time. People of Jewish ancestry have been tested for BRCA1 and 2 for, upwards of 30 years. But depending upon when somebody was tested, we know about many more genes that can increase the chance of causing hereditary breast or ovarian or prostate or pancreatic cancer. And here's just a handful list of some of these genes that are more related to breast cancer. But my main message here is that you, or if a loved one was tested for BRCA1 and 2, and only tested for BRCA1 or 2, it may be time to go back and revisit genetic testing with a healthcare provider because the testing has expanded so much in the past 20 years. Another condition that I wanted to talk a little bit about that is more common, there are certain mutations in genes that are a little bit more common, was with the condition that's called Lynch syndrome, named after Dr. Henry Lynch. And this is a condition that can primarily cause colorectal cancer as well as uterine cancer. So we really look for families that have colon and uterine traveling together. However, Lynch syndrome, you can see other gastrointestinal cancers like pancreas, small bowel, stomach. You can also see ovarian cancer with this syndrome, and there's other cancers. You can see kidney, bladder, prostate in men. So something else that there are certain mutations in the genes known to cause Lynch syndrome that can be a little bit more common in people of Jewish descent. And doing the testing, really the idea behind it is to help people identify whether or not there's obviously an increased risk, but so they can take action on that increased risk and they can know about it prior to a cancer developing. Because if somebody has a hereditary cancer risk, you can offer those people increased screening as well as starting at younger ages. So for instance, for breast cancer for women, you may start screening in the 20s instead of waiting until age 40. You're going to offer not only mammograms, but an imaging test called breast MRI, as an example. For men, you may start screening for prostate cancer at 40 instead of waiting until 50. For some cancers, there's actually medications that you can offer that can help reduce the risk of developing cancer, and that's called chemoprevention. And then some people may choose to undergo a risk-reducing surgery to significantly reduce the chance that they would develop that cancer. So as an example, for women that test positive for BRCA1 or 2, when they're done having their family and they start to get into their 40s, we typically recommend removal of the ovaries and fallopian tubes so that it significantly erases the chance of developing ovarian cancer, because ovarian cancer is one that does not come with early warning signs and symptoms. And Angelina Jolie, about a decade ago, came out with her story about testing positive, and that really kind of led to an explosion of understanding about these genes in terms of the general population, and more people starting to ask their healthcare providers to get this type of testing. So again, we don't do this just to really scare people, but this is really actionable. There's things that people can do to help minimize the risk or detect cancer as early as possible when it is the most treatable and curable. And in terms of understanding when somebody is a candidate for genetic testing for hereditary cancers, it's usually based on family history. So is there a family history of cancer? However, for people of Ashkenazi Jewish descent, the guidelines have come far enough to really suggest that anybody of Jewish ancestry, regardless of whether or not there is any family history of cancer, should consider genetic testing. And that's because there are studies that show that about 40 to 50% of Jewish individuals who test positive have no family history of cancer. And that could be because a family really has significantly more men than women, and men are a little bit less likely to get cancer than women. Or families are very small and you just are not seeing people express it. As we saw, that the cancer risk isn't 100%. It's higher than average, but it's not a guarantee. So for those reasons, the recommendations really have advanced to the point where really anybody of Jewish ancestry could consider genetic testing. Okay, so we're going to switch gears and we are going to talk about a condition that is known as or called dystonia. All right, and while I'm talking, I want to get this playing. Okay, so dystonia is a condition where it's known as a movement disorder. And so the movements are characterized by sustained or intermittent muscle contractions that cause repetitive moments and or postures. So you can see in the video that this gentleman's hand is really kind of twitching back and forth, and he has a small tremor. it's uncontrolled. So this is what essentially dystonia is. The movements can be patterned, and sometimes they can be twisting. Again, you can see a little bit of a tremor here with this gentleman. And with dystonia, the tremor or the contractions can often be worsened by voluntary movement. So when you go to do an action, it can actually trigger it to have kind of an overflow of muscle interaction and cause the symptoms to become kind of more prominent for a very short period of time. It not only impacts the arms and legs, but sometimes it can impact the eyelids, the mouth, or the larynx. The age of onset, sometimes it can start when people are very young. Other times people don't get symptoms until adulthood. Dystonia itself can be a completely isolated symptom, or it can be a symptom that's part of a larger neurological spectrum. So people are having multiple neurologic issues. There are a wide range of treatments for dystonia with medications, Botox. Sometimes it can be surgical, where they do the deep brain stimulations like they do for individuals with Parkinson's disease. And there are many different forms of dystonia, and some of which can be genetic in nature. And so there's a particular type that's called DYT1 early onset dystonia that typically presents in childhood or adolescence. And it is a type of dystonia that's considered isolated dystonia, where dystonia is the only symptom. And there's a gene that's called TOR1A, where there's a particular genetic mutation, and this is the genetic lingo for the mutation, that is responsible for about 80 to 90% of dystonia in people of Jewish descent. Now, it's not as common as some of the other conditions that we're talking about, where the prevalence is anywhere from about 1 in 1,000 to 1 in 3,000. But if somebody is Jewish and they have dystonia, doing this testing is something that really should be done standardly to see if it is genetic, to identify the exact type of dystonia. And the reason for that is if you can tell somebody, oh, you have the DYT1 early onset dystonia, you can be somewhat reassuring to families that the dystonia is going to be the only symptom that's going to develop, and they're not at risk of developing other neurologic symptoms. The other interesting thing about this condition is that the presentation is variable in families, meaning people can present a little bit differently in terms of what body parts are impacted. And it's also not fully penetrant. Penetrant or penetrance is a genetic term that is describing if you have the genetic mutation, what is the chance that you will actually develop the signs and symptoms that go with that condition? And for this gene, the penetrance is about 30%. That means about 70% of people who have this particular mutation will never go on to develop signs and symptoms. Why is that? We don't have a great understanding, but the general belief is that there's probably other genes that people have that can influence whether or not the mutation expresses itself and people go on to develop signs or symptoms of dystonia. Or there can be other environmental triggers or lifestyle factors. So for a lot of neurologic conditions, exposure to heavy metals can increase the risk, or having head trauma can sometimes increase the risk of developing signs or symptoms. So you can have the mutation not develop symptoms, but then these other things happen to you, and that could potentially kind of trigger the condition to occur. So again, really wanted to highlight this condition because of how important it is to identify the right type of dystonia in people of Jewish ancestry, to be able to kind of explain that this is going to be the main and only symptom. It can sometimes help alleviate some concerns that people are going on to developing Parkinson's or other more severe neurologic conditions. Okay. So we will wrap up with talking about recessive genetic disorders. Again, just to go back to about 20 minutes ago, for recessive disorders, we call people carriers, because they are basically born with one gene that's working just fine and one gene that is not, that red band. People that are carriers of the disorder, again, themselves are not going to have it, but they can potentially pass it down to their children if they have children with somebody else who is also a carrier for the same condition. So when two people come together that are both carriers,